So welcome to part two of our introductory module. Within this part, we are going to talk about the anatomy, potential causes, which is pathology or pathophysiology of lower back pain that you might be encountering. So you probably heard of a lot of these structures already within the lower back. So part of what we try to do right now is we try to improve the knowledge that you have about these structures and how they might contribute to the lower back pain that you're having. Um, so within lower back, obviously there is vertebrae. Vertebrae are bones within the lower back. So in the lower back, we usually refer that as the lumbar spine. There are five levels over there. Um, we are having, joints that connect these five vertebrae, and they are the facet joints. Sometimes we can see wear and tear within those facet joint. That could potentially be one of the factors that causes pain within the lower back. But on the other hand, we'll probably be hearing about, a slipped disc or a herniated disc. So they are what we refer to a intervertebral disc. So the intervertebral discs are structures that sit between vertebrae, which are the bones. They are jelly-like substance that's usually serve as a cushion and improve the mobility around the lower back. From time to time, there might be injury that's happened within the disc that could cause a disc to slip or herniated, and that could be potentially another type of lower back pain or another cause of lower back pain. Other than that, there are muscles, ligaments, fascia. There are also nerve and spinal cord within the lower back as well that will be well, contributing to, some type of lower back pain or, actually a lot of lower back pain that would also have an involvement of nerve and muscles as well. Um, a very, very important things to note is these structures or pathologies or problems with these structures usually don't appear alone. They're usually a related relationship between all these structures. So you would probably have a facet joint problem and that causes, wear and tear, that causes, increased friction around the joint, which caused muscles to overexert or becoming overactive because it's trying to protect the environment. Then it causes a muscular problem as well as the muscle, let's say, contracts too, fiercely, it will probably cause the disc to have, excess pressure that causes a disc to come out and slip. That causes a nerve impingement, potentially spinal cord impingement as well. So that's why, all these structures it can be a contributing factors, and most of the time they don't. They're not a standalone issue. They're usually a correlation with each other that causes a pain that you're experiencing. Structural pathology or pathology is what we usually refer as a structural change. This is what we just talked about. There could be degeneration of the disc that causes the disc to herniate, to slip. It could be a facet joint irritation because of excessive wear and tear. It could be a muscle strain, like we said, a secondary problem. Usually these changes can be seen on imaging, which is when physios or doctors referring you onto an X-ray, MRI, CT, or ultrasound. So these are the things that we can see on a picture or on a scan. It usually answers part of the questions of why a person's having pain. On the other side, we have to remember that we are a living organism. We always be moving, we always be doing different things. Even though when we are resting, lying down in bed, there is our body and our structures interacting with the environment as well. So this is what we talk about, the pathophysiology or the functional deficits. Um, there are a lot of different factors that can cause pain as well, other than structure or together with structure. It could be nociception meaning that the pain signal within the body is being interrupted. So there are different kind of presentations as well, but you can imagine, let's say, if you have a paper cut on your fingers, it is a very, very tiny injury, but at the same time, it can bring you on immense pain. So consider that it is very tiny injury, but at the same time giving you a lot, or your brain interpreted as a major insult, giving you a lot of pain to that area. The disproportionate over there is a nociceptive or excessive nociceptive response that we're talking about. So we also have to consider that in a lower back pain condition. So is the structure or structural deficit actually reflects the pain that the person is experiencing? If a pain level or a person's pain level is excessively more than what a structural deficit is, as a physio or as a healthcare professional, my job is to first educate the client so that they understand what they're having right now and what they're experiencing are different. And then my job is to bring that pain level down to an acceptable level so that two things matches together. So this is what we talk about nociception. It is a quite a complicated process because our body is designed in a very mysterious way. Sometimes our body overreacts, sometimes our body underreacts. So it's the pain signal within the body. So that's why yeah, it becomes slightly more complicated. And that's why from the assessment point of view, our physio will need to be making sure that we are considering that part as well, like managing a person's pain in the lower back. Other factors could be, like we said, we are a moving organism. We always be moving. We always be doing activities. So we're talking about motor control, meaning the body interaction or the structural interaction between each other. How is our muscle interacting with our joint? How is our joint interacting with our ligament? How's our ligament interacting with our nerves? So all these things could play a, factors of a person's pain as well. You probably have heard people, or maybe yourself, having a low back pain for an extended period of time. It can get quite intense. But when a doctor refer you for a scan, for an X-ray, let's say, they will come back as, oh, there's nothing wrong with it. Let's refer you on to an MRI. And an MRI come back as, yeah, there's a bit of degeneration around there, but no, there's nothing to worry about. But at the same time, you're having a lot of pain. You're having, you can't do, your gardening, you can't do cooking for an extended period of time. So those are the things that we actually be looking at is your muscles working well with your bone? Is your bone working well with your ligament? Are there compensatory movements? Are there overactivities in some sort of area and underactivities of some sort of area? Meaning, is there some part of the body that's working very, very hard to compensate for body part that's supposed to be working but not working because they're lazy or because of different reasons? We look at also secondary deficit. Secondary deficit, meaning that if, let's say, a scan come back as, oh, we've got degeneration around L4-5 with evidence of nerve impingement of L5 nerve roots. So naturally, from a physio brain or a doctor's brain, we'll think about, okay, you probably have a referred pain or low limb pain on one side where the impingement happens. At the same time, the body also recognizes that. So what our body do would usually be trying to protect or trying to recover, reverse the process. The first thing that they probably do is to contract their muscles to, make sure that we're protecting. Almost like someone punching you in the guts. The first thing that you do will be holding yourself into a ball or the muscle contracts. That's what basically the body does when you start injuring your lower back. So we look at, and that's what we call a secondary deficit because of the overcontraction of the guarding of the muscle that can also contribute to the pain that you're experiencing. That's why what we're trying to do is we need to identify, yes, the scan tells us it's an L5 nerve root problem, but we also need to manage what the problem produces. Another problem that the original problem produces, which is the muscle contraction or over contraction. So there's a lot of moving parts that we're looking at. There is a lot of factors in consideration that we have managing a lower back pain. So especially for a person who have an extended long period of lower back pain, 5 years, 10 years, 20 years, we are going to be looking at a lot more secondary deficit, tertiary deficit together interacting with that original deficit as well. So that's how what we need to do is we need to sort of look at or piece look at bits and pieces and try to piece them all together to figure out what that puzzle tells us. Yeah. Last thing that we usually talk about is your pain perception. We briefly talk about it about nociception in here. Pain perception is another area that we look at very closely. Meaning that you probably heard of a lot of times people say that pain is in your head, which is partly true. We do know that probably flowers or plants, they don't have a brain, so they probably wouldn't be able to feel pain. But as human, because we have a central nervous system, we can experience pain. So if we take out our brain, we probably don't feel that. And the problem with that as well is our brain is sometimes very good at heightening some sort of sensory input from external environment or even internal environment. We use paper cut as an example, but we do know that if a person has been experiencing pain for an extended period of time, our brain can heighten some sort of pain signal, meaning that you'll probably be experiencing more pain than what your body is or what your injury is actually is. It could be other factors like stress and anxiety. So people who are probably in a high stress situation, people who probably suffer from anxiety or depression, those people would potentially be experiencing more pain as well because their brain tells them to. So that's why we have to also identify all those factors. Some of these factors might not be a physio management, it might be a medical psychological management, but that's also something that we have to consider as a physio through this process. And if it's required as well, we do have you referred to external healthcare professionals if required. So that's probably everything that we need to talk about today. Um, I think to wrap up, we did talk about the anatomy, we did talk about the pathophysiology, so the reason of pain. Um, Pain is multifactorial. It is a lot of moving part that we're looking at. So that's why, from a treatment perspective, many times if we're looking at purely exercises, which a lot of the physios out there are offering, might not be exceptionally benefit because they probably look at only one area of the problem, which is probably the movement, mobility, and strength. But we actually neglected the other part, which is the painful part, which is the other part of pathophysiology, the movement part as well. So that's why, from my perspective, in managing lower back pain, in managing actually a lot of other conditions as well, we have to look into other parts. We did mention about the 5 stages of recovery, which is a very structured way of looking at recovery. We have to move through all 5 steps in order for us to actually confidently say that we have managed well a person's lower back pain. And that's why we do ask the patient active participation. And this is probably part of why we're having this module over here to educate people around the recovery process, the pathology, and what they need to do to help themselves through the process.